Someone comes in and says, I want to have a lot of fullness, but I want a really small breast. And you can't have that. You can't have one of those, the other. When I switched from saline circumareolar to gel circumareolar, my capsular contracture went from basically 0 to like huge. It went up 10 times. You never want to get that. That's the one thing I want to avoid at all, if at all possible in my practice, because you can't reliably fix it. I can fix almost anything else.
How does one find a good plastic surgeon? What do you look for?
No idea.
I am here with a plastic surgeon who really doesn't need any introduction. However, in keeping with tradition, it is my absolute pleasure and joy to introduce the one and only Dr. Paul Whidden, who most of you have heard of, especially if you're in Alberta. Now, Dr. Paul Whidden, you are widely recognized as one of Alberta's leading cosmetic plastic surgeons, renowned for your expertise in breast augmentation, breast lifts, tummy tucks, and rhinoplasty procedures. You're certified by the Royal College of Surgeons of Canada, and you're a member of both the Canadian and American Societies of Plastic Surgeons, so both. You completed your undergrad with a Bachelor of Science in Queens in 1990, right in Ontario. Where did you do your med school?
My med school was in Edmonton.
Is in Edmonton.
Yeah.
Okay. And I happen to know that you graduated with distinction.
Yes. Yeah.
Yes. And you also did your residency in Edmonton as well.
Which was an amazing place to do it.
Yes, you're somewhat of an Edmontonian, maybe.
Yeah, I was there for 9 years.
A little bit, yeah. Okay, cool. Now, then you went on to do an advanced fellowship training in UBC, University of British Columbia. What did you specialize in there?
It was a fellowship year, and half it was breast reconstruction.
Okay.
The other half was microsurgery and hand surgery.
Hey, amazing. There's a really interesting fact about you that probably most people know, and it's related to your father.
Right.
So do you just want to share with our listeners?
Yeah, so he was a plastic surgeon in Calgary, practiced about 25 years before I started.
Okay.
And he was very well known and respected in the city, and also did a lot of breast surgery and tummy tucks, and similar to my practice.
Yes. So I've before I met you, I've heard about the father-son combo.
Yeah.
I think so. You're second generation plastic surgeon.
We worked together for about 10 years or so, maybe a little bit longer, and then he retired, and I moved into this place.
Okay. So that would have been interesting dinner time conversations.
Yeah.
Probably. Awesome. Okay. Now you are a respected leader in breast augmentation, and you regularly share your expertise as a consultant and speaker for Allergan Canada.
Yeah. And also present at different meetings as well.
Conferences.
Yeah.
Okay. Well, welcome to the Illuminated Dark Room podcast, conversations on breast health and beyond.
Thanks for having me.
My pleasure. Especially, I know you're on call today, and so today we'll talk about plastic surgery, especially the cosmetic aspect of it, breast augmentation. There's a lot of information about breast augmentation that people have perhaps wondered about, and I'm looking forward to having this conversation with you about, like things like mid, size, shape, placement, imaging, of course. So yeah, I'm looking forward to this. Now, I wanted to start by asking you a question that a lot of people think they know the answer to, but maybe not. When people hear the word plastic surgery, they hear plastic. And their preconceived notions about that, the fakeness, the judgment that comes with stigma and all that. So, I think of the Barbie song, Life in Plastic. So there's the visuals that go with that. So what is plastic surgery, and how did that word come about?
Yeah, this is a question you had asked to get into residency. So it's been about 30 years. So plasticus is a Latin term to mean to mold, shape, reform. Plastic surgery is kind of questionable, arguably the oldest surgical profession, and it was back like 5,000 or 6,000 years ago. They would reconstruct noses by moving tissue from arms to noses, and this was done by barbers. And then in the war, they had to get really creative to deal with these terrible injuries and fix burn wounds and things. So these surgeons became very creative in moving tissue and recreating and reconstructing things. And that's really where kind of plastic surgery became.
That's yeah. I looked into that. And I was quite amazed by that because a lot of people don't know that, and that's why I thought it would be a good place for us to start. And I know we touched about it a little bit on your in your bio, but what inspired you to get into the field of plastic surgery and then segue into, things, breast augmentation?
Well, I started off probably because my dad was a plastic surgeon, and you grow up and you want to be your dad and emulate your dad, and so it was always something I wanted to do, which was totally not realistic. It was just I want to be a plastic surgeon because my dad was. It turned out that it fits with my personality very well, and it's turned out very well for me. I'm very creative. I'm also probably I'd be an architect if I wasn't a plastic surgeon. So I like considering dimensions and form and function and all these things, and that really plays really well with breast augmentation surgery, where these are all very important facts to think about.
I would imagine that being a plastic surgeon, there has to be some sort of an artistic component, to your life, a
Yeah, and people
skill.
ask me that all the time.
Yeah.
And I think it's more. I'd rather have an architect or an engineer than an artist. Like there's some artistry for sure, but it's more about getting symmetry and getting dimensions right and all these things. And I think that's more of being an architect rather than being an
Right.
artist.
True.
Whereas an artist, like a Picasso, you don't want to necessarily have your face look like a Picasso.
Right.
So it's a combination of the two.
Yeah, I like that. And when I think of exactly what you mentioned, engineering, architect, I think of precision as
Yeah,
well.
yeah.
So
Yeah, exactly.
okay, makes sense. And then what made you segue a little, hone in more so into breast augmentation, amongst other things, of course. But
Well, I did my fellowship in breast reconstruction, so I came to town and I was doing that. My dad had a big breast surgery practice, and when I started off, I didn't have a lot of OR time in the hospital, so my dad had a surgical suite, so I had time to use, and I had some spare time in my hands, so I just got busier and busier because I had available OR time and available personal time to do this, and it just worked really well with joining my dad's practice, his knowledge, his experience. I got to kind of practice and learn from him and use him as a sounding board. And so probably a lot of it's driven by his practice.
yeah, I think that's kind of really cool, actually.
Yeah.
When you think of a dad and you guys got to work together and bounce ideas and knowledge. Yeah.
Yeah,
That's
and
pretty amazing.
as a surgeon, it's so incredibly important to have colleagues you trust and who are good and who are humble and who you can talk to.
Yeah.
And to have my father, where in my first couple years in practice, I could sit down and I say, how am I doing? Am I doing the right job? Am I, how can I improve? And I was able to grow off his knowledge.
And he's going to tell you the truth.
Yeah. Yeah, whether I want to hear it or not.
Whether you want to hear it or not, yeah. So that's amazing, actually, and I'm sure that's what makes you the great person that you are today. Now, what is breast augmentation?
Well, people, if you just think simply, like most things, simply it's just making your breast bigger. But it's much more complex than that because it depends what your breast looks like and what it's like. If you have a larger breast, a breast augmentation is just making that a little bit bigger. You won't really see much difference. If you have no breast at all, you're not just kind of making that breast bigger, you're creating the whole mound. If you have, breasts that are really wide apart, you can do things to make them closer. So it's not just taking the breast and just blowing it up. There is some subtleties in changing the breast shape. And things like that.
Yeah, because breasts. Sorry, go ahead.
No, but in general, you're taking a breast and you're modifying it by an implant of different size and dimension to enhance it.
Yeah, I can't wait to get into that. You're right. Breasts come in different shapes, sizes, wide, width, close together, tubular, all that. So, yeah, it's not as simple as people seem to think, which is why I asked that question. What are some of the most common reasons why people would come to you to seek augmentation?
Well, my practice, most common thing to do is breast augmentation, obviously. And about 80% of my patients, 79%, last time I checked, are moms with a couple kids between 35 and 45. And that's like my bread and butter.
Sounds like me.
Yeah.
Totally.
And it's amazing how these patients come in. They're all the same person, same complaints. They breastfed a couple kids. They've lost all the fullness in their breasts. They have deflated breasts. They think they're droopy, but they're not. They're deflated.
Yeah.
And they just want to, they don't want to be someone different. They just want to regain some of that volume that they lost.
Yeah.
And those are the real.
Yeah.
Those are the great patients.
I can totally relate to that for sure. Now, what should one consider before getting an augmentation? And I ask this question keeping in mind too, that's most of your patients, but you do have patients, and I see them that have had children, or that are considering having children. So what is something that someone should consider before getting?
Well, you want to be fully developed. I typically wouldn't operate on many people who are under 20, but certainly under 18, that'd be very rare. So you want to be fully developed. I want to make sure the patient has a very reasonable expectation of what they are. I want to make sure that they're healthy, they can tolerate an operation. I want to make sure that that they understand what I can do and what I can't do. As far as a patient, what they should do before having it get it done, that's tough because I don't know how to answer that.
You mean in terms of the breast nursing patients or just generally?
You wouldn't want to do it, while you're pregnant, before you get pregnant. Like, I wouldn't get a breast augmentation to get pregnant in the first couple months. It happens.
It happens.
But it's unfortunate because you get this augmentation. They look strange initially. By the time they look great, your breasts have already changed. You never get to experience them and enjoy them. But I do get patients, like one patient a year who comes in to see me and gets breast augmentation and then has an oops. And they always blame me because their husbands can't keep their hands off.
Yeah, exactly.
And it's always sad because they never get that experience until later. But, implants don't affect your ability to breastfeed, so you can get them done before having kids. But don't get them done right before having kids.
Right, and preferably after having kids, right? Yeah. Have you ever turned down anyone for...
Oh, absolutely.
So could you give me why?
If I think that the patient has body dysmorphic syndrome, they're very unrealistic in what I can do.
Like they want to be perfect.
Yeah, and I've had 2 or 3 patients in my whole career, so that's not very common. And maybe that's my medical office assistant helping me out and directing those one other way. But I don't see them often. If someone wants a really big implant, I'm happy to send them to someone else who's going to do that. I don't do that. If someone has just an unrealistic expectation of what they're going to have, I will tell them what I can do, and most importantly, tell them what I can't do. Yeah. And then if they say they want something different, I'm more than happy for them to go somewhere else. So I don't have a hard time turning people down. The most important thing a surgeon can do is say no.
Yeah.
But it's also the hardest thing.
Yeah. I mean, better no than wake up and have a surprise, right?
Oh, yeah.
Now, there are a lot of myths about breast augmentation. What is probably the biggest, or at the very least, the most annoying one for you, I would say?
Well, there's lots of myths like implants last 10 years. These aren't annoying. These are just beliefs, and they come from some partial knowledge and come from the internet. People have these ideas about what an implant can do, and then there's a reality of what they can't do. And a really common one is someone comes in and says, I want to have a lot of fullness, but I want a really small breast. And you can't have that. You can't have one of those, the other. Fullness, which is upper pole shape, is driven by volume. So you put a little tiny implant in, like something like that in someone, and they're like, how about that little implant? They point to that implant. And I'm like, you put that in your breast, it's going to sit at the bottom, and it's going to do nothing at the top.
Right.
It's like a glass of water. You have to fill the glass of water up. You have to fill the breast up. So with a small implant, you get very little shape. And with a big implant, you get a lot of shape.
Right.
And a lot of people want these small, little, compact, perky breasts. And unless you start that way, you can't get that from an implant. So those patients, we have to have a conversation about, you need a big enough implant to change the shape. And then it's about finding that nice balance where it's big enough to change the shape, but not so big you're uncomfortable with the size. And that's a really common thing we hear all the time here. I want perky, small breast. Or I don't want to be any bigger, but I want it perky. Well, that's an impossibility.
Yeah. Could you combine it with a mastopexy reduction?
Upper pole shape is still driven by volume.
Okay.
So yeah, if you have a very heavy natural breast, a small implant, you won't see it. But then if you do a lift and a mastopexy to tighten up that lower pole, you'll see it a little bit more. Yeah.
Okay. So upper pole fullness
Driven by volume.
driven by volume.
Yeah.
Interesting.
Yeah. It's driven by projection, really, but that goes hand in hand with volume.
Okay. So we have a bunch of implants
Yeah.
and on the table, which I would love to talk about. But before we do that, let's do some rapid fire questions.
Okay.
You can say whatever you want. Saline or silicone?
They're both great.
Okay.
I did 10 years of my practice doing purely saline, and I've done the last 15 years almost purely gel. They both work great. My saline patients come back and see me. They have great results.
Okay.
They're a little firmer. There's some slosh, maybe a little more scalping, subtle little differences, but they both work great. These days I use cohesive gel. 98% implants sold in Alberta are cohesive gel.
Okay.
They're, they're softer. They feel more natural, less scalp. Yeah, they're great. They last a little longer too.
Okay. Awesome. Over or under the muscle?
I put mine under.
Under the muscle. Okay.
Yeah.
This is interesting.
Yeah,
Textured or smooth?
smooth. Yeah.
Peri-areolar or an inframammary incision?
Inframammary. So if
Really?
you just, oh yeah, if you just look at the evidence,
Okay.
if you're purely looking at scientific evidence, there's no other option for you. So an areolar incision has a 10 times higher likelihood of capsular contracture than an inframammary fold incision. You can't argue that point. It's so well known. And in my practice, I went from a circumareolar incision with saline implants. So these go in empty. So you take this little thing and you put it through this tiny little hole. It goes in empty,
Right.
and you can fill it up. And those work well. But when you try to push a big implant through that small hole, you get bacteria in the surface, and it causes a capsular contracture. And when I switched from saline circumareolar to gel circumareolar, my capsular contracture went from basically 0 to like huge. It went up 10 times. And that's exactly what the evidence shows. Then I switched to inframammary fold. My capsular contracture rate is now as close to 0 as you can be. So you can do either operation, but if you're doing it based on science, you cannot justify a circumareolar incision.
Interesting. Now, you mentioned capsular contracture.
Yeah.
What is capsular contracture?
So all implants, you put it in there, any foreign body, sliver in your hand, implant, whatever, knee, your body produces a thin little layer of tissue, very thin. It looks like wet tissue paper when you see it. It's like there's almost nothing to it. It's just this glistening surface. And that's a capsule.
The capsule over it.
That's the capsule.
Right.
Yeah. And there's the implant capsule, and then there's the body's capsule. And that capsule is very thin and pliable and allows that implant to sit like that.
Okay.
And if that capsule shrinks, it turns that into a ball. Okay. And that is called capsular contracture. So a capsule's a normal thing. If that capsule there's a problem with it and it shrinks, it becomes that ball, which is capsular contracture. You never want to get that. That's the one thing I want to avoid at all, if at all possible in my practice, because you can't reliably fix it. I can fix almost anything else, no problem, but capsular contracture, that's a tough one.
When you, and I don't know if you know the answer to this, but when we look on mammograms sometimes I'll see an implant that's heavily calcified.
Yeah, yeah. It's like an eggshell.
Right.
Yeah.
Like it's just literally like an eggshell, you know, some of them more than the others. And that's
a capsular contracture. So capsular contracture, there's this chronic inflammation. And the inflammation causes that capsule to shrink, but it also causes calcification. Okay. And if you've had a capsular contracture for a long, long time, you get that thick calcium lay down. And you saw that a lot more in the past with the older silicone gel implants, the more liquid silicone gel implants. They develop more capsular contracture. I think you see it more with a subglandular implant, long term. But anything that leads to that chronic inflammation for a long enough time will get calcification around it.
Does the implant get pushed up too at all? Or?
With a capsular contracture?
Yeah.
Yeah, it gets squished, but it tends to, the way the body works, it tends to sit up higher. So it tightens up here, sits up there.
Okay. So less chance of that if it's inframammary because of the bacteria.
Yes.
Yeah.
So capsular contracture is caused by either blood in the space. So if you have a hematoma, you got to drain it, or bacteria in the implant called a biofilm. And any bacteria in the implant can lead to a biofilm. So if you're putting it through here, you're more likely to get it. IMF, less likely to get it. We also use Keller funnels, which are like a pastry funnel. You stick it in there and squish it in, and so it doesn't touch the skin. That's an important thing. So
okay.
you want the implant to go in as quickly and as atraumatically as possible and have no exposure to the environment. So we literally open the implant. We squirt fluid inside the implant. So there's a soap on the implant.
Okay.
Inside the container. Then you lift up the container. So if anything was to land, it wouldn't land on the implant, it would land on the soap.
Okay.
And then you take that, you put it in this pastry bag, which is also filled with that same soap. It's bacteriacin.
Right.
And then you put it in the space. So the implant is only in the air for a matter of seconds. And then you want to close it up, and you want to have as little contamination of the implant as possible.
Well, this is great information. Cool. Now, what kinds of implants are on the market now? As we're looking at this display, and my eye is really drawn to that blue thing there. I'm not really sure what that is.
So this is for breast reconstruction. So this is a tissue expander.
Okay.
And you put this in under a flap, and then you put a needle in there and fill it up. But this is under your skin. So what you do is you take this needle, and it will point to where you put your needle.
Okay.
So you have skin over top. You know where to put your needle. You stick your needle through the skin, fill it up. So it's a tissue expander. That's for breast.
Okay, and that comes out
And
later.
then that would come out, and then you'd replace it with a permanent implant.
Right. Okay.
Yeah.
And so what do we have?
So implants in the market, there's 3 implants in the market in Canada. There's 4 in the States. There's Mentor and Allergan, and those are the 2 big companies that have been around forever.
Okay.
They've been around for, longer than I've been doing this. And then there's also Sientra, which is new on the market. It was on the market, then came off the market, then it's back in the market. And it's new both to Canada and the States.
How is it different from these, or is it just a different company?
So if you look at the company, when they come out with these, they tell you how they're so much better, and there's this better and that better, and they look better and they feel better and they're safer. They're really, as far as I'm concerned, there's no real difference between these. The shells they're a silicone shell. The fill is the exact same. There's subtle differences in dimensions available, really subtle. But someone will say, I use this implant and therefore you're getting a better result. That I don't believe that. I think any really good surgeon can get a great result with any of these implants, whether it's saline, textured, smooth, Allergan, Mentor. So I think people like the new and the best.
Yeah.
Because they think it's shiny and fancy and better. But
social media driven now too. There's so much in social media, so people are like, oh.
Which is really harmful in a sense. Because you can use it for education, but you can also use it to push maybe an agenda. So when something like that comes out, my biggest fear is what's that going to be like in a year or 5 years or 10 years? Is it going to pan out and be as great as it sounds, or is there going to be a problem with it? There was with the Allergan Trail, there's 3 stiffnesses of them, 2 from 1, 2, and 3. And 2 from 1 is the softest implant. So you think, well, let's use that because it's going to be the softest breast. That's great. Right. Brilliant. So you use it, and you see the patients at 6 days, they look awesome. 6 weeks, all patients look great at 6 weeks, and they feel great. You see them at a year, and all of a sudden they kind of have wrinkles on the side, way more than I thought they would. And so then I changed True Form 2, and the wrinkles are better. So you don't pick that up for at least a year.
Right.
So when something new comes out, some people will just jump on it and use it like crazy. You got to give it a year or 2 or 5 to know if this is going to be a real problem or if it's going to be something great.
Right.
Something like this, textured implant, which is, I use these. I went to Sweden and trained by a guy named Rankworth, who was brilliant, and learned how to do these. And I loved them, and they were great. And I used a ton of these for about 5 or 6 years. But then I started to see some asymmetries with these that I didn't get with those. And then a little later, it was found out that these lead to breast.
Yeah, we'll talk about
ALCL,
that. Yeah.
Which is exceedingly rare, but it took 20 years to figure that out.
Yeah,
and
interesting. Although I did hear that some smooth ones do, but we will talk about that later. And this is textured as well, right?
That's textured as well, yeah.
Exactly.
Different texture.
Okay, well, that's cool. We'll probably come back to some of these.
For sure.
Interesting you said under the muscle. I know that you I know because I have some friends like that are competitors, like body competitors, and
Yeah.
putting it under the muscle. Sometimes when you're flexing, you can kind of get that. You can almost see the implant,
For sure. Yeah.
but you still think that's the
It's what I do. I believe in. So they used to do what's submuscular, where they would leave the origin of the muscle intact. And when you did that, you get really significant animation when you tense your muscles.
Right.
And that muscle tightens and the implant shoots up in the sky. And that's implant animation. And it can be dramatic. Most people, and certainly I, release the origin of the pec muscle, which allows the pec muscle to raise up. Kind of gives a little bit of the benefit of a subglandular, but the benefits of a submuscular. And then when you tense your muscles, it doesn't fire the implant up the same way. So your animation is significantly less.
right.
And but that's the one downside of putting it under the muscle is that animation.
Yeah.
In my mind, there's 100 different advantages to putting it behind the muscle. Capsular contracture rates are lower. It's better for mammograms. It's better for breastfeeding. Better to have nipple sensitivity. I think they do. Some of them, some glandular do great forever and ever and ever, but some people end up with this blind bottom tube sock. And you'll get the odd person who gets a subglandular. They love it, and then it kind of stretches out. They want more shape, so they come back and get a bigger one. They love it, stretches out, get a bigger one, and then they come in with 800 cc as implants, the biggest implants you can get. There's nowhere to go, and you don't tend to see that with submuscular as much. I see patients who are my dad's old patients. So I see patients who are 50 years out.
Wow. Yeah.
And I see submuscular, subglandular. And if someone comes in with a 30 or 40-year-old implant that's submuscular, it's usually a super simple fix. You're just changing out a bag or subtle things. But when they come with the subglandular, it can be fine, but it can be a real problem and a very difficult problem. One problem with the subglandular, in my mind, is there's this. We're taught that if you have 2 centimeters, let's say, of a pinch, you can pinch 2 centimeters of tissue in the upper pole. You can put an implant in. And because of that, you won't see the rippling.
Right.
Okay, because it's covered by that 2 centimeters.
Right.
And that's great. But you're making that decision on a 20-year-old who's going to become a 50-year-old. And he's going to have 2 kids. And that 2 centimeters, maybe they're going to get bigger and it's going to be 4. Or maybe it's going to go down to 1.
Right.
And so you're making a decision on someone at this point in time when you know it's got to change.
Right.
And so while it might work great at 20, it may not work great at 40.
Yeah.
And if you put them in front of the muscle, it's very difficult to change them to go under the muscle.
Right.
You've kind of burnt a bridge.
Right.
Even in a bodybuilder, they get so lean and you get this terrible rippling and scalloping. Okay. So even in bodybuilders, I put them under the muscle. And if someone wants them in front of the muscle, that's fine. Like they can do that. But I'll say you should go to this person or this person, a specialist who does that operation.
Yeah.
Yeah. And
Which is fair. Yeah.
and that's, it's fair to do that. And some people specialize in that, but it's just not what I do.
Yeah. So what I'm hearing is, because I know some of the issues that some plastic surgeons have is somebody who's going to come with a picture. I want to look like this.
Yeah.
But there are a lot of factors that you have to consider. So what I'm hearing is trust you with your experience, and you've worked with a bunch of implants over the years to pick what is best for the patient based on a lot of factors.
Yeah, for sure.
Right. Yeah.
And I get patients come in and have pictures, but I say, okay, I'll look at the picture, but it's not, can you make me look like this? It's, when you're done, can I look like this? Like, is this reasonable? Right. It's not me being able to match a picture.
Okay.
It's me saying that picture makes sense. And I look at that picture, that looks like a full projection implant, therefore we'll do this. Okay. It's not me, it's not like just choosing out of a brochure.
Okay, cool. Do you often end up changing areolar size when you do augmentation?
Never.
I mean, all right, because now you did.
So
you mentioned the inframammary and obviously bacteria, but I'm assuming there are some women that come because they want to change the size of the areola.
Yeah, so you can do that. You can do just an implant itself. If you put it under the muscle holds everything really tight. The skin's actually pretty loose, and then slowly the muscle stretches out. The deep tissue stretch out. When you put it in front of the muscle, the skin tends to be tight. So you can get more areolar stretch with the subglandular. than you do with the submuscular. You can. People come and say, like, I don't like my areolas, they're kind of big and can make them smaller. I usually say, you know what, when you put an implant in, your nipples are probably your areola is going to seem smaller because your whole breast gets bigger and your areola stays the same. So I usually would say, let's expand your breast, see what they look like afterwards, and then you can reduce them if you want to. You can do an areola reduction. It's not the greatest operation, so I don't do it very often. And when I do it, I warn patients that it may not be as good as they think. Now, if you're doing a breast lift, like a true lift with an anchor scar, that you can make an areola small and they stay that way, and it's a great operation.
Okay. All right. Yeah. No. Yes or no? Questions now. Or depends. Implants cause cancer, yes or no?
No. We know that for a fact. There's been lots of studies. One study, which is actually from Calgary, it's a brilliant study, because in Calgary, in Alberta, there used to be a billing code for breast augmentation. So people could get their breast augmentations covered by healthcare.
No way.
In Alberta. This is so long ago. Yeah. And so everyone was doing it. And my dad, like, this is back in my dad's day, right? That's why I know this stuff. So then a surgeon in the foothills, he got a good idea. Well, let's, because people are billing this code, we know who's got breast augmentation. So we can actually pull up a database of who's had breast augmentation and then who gets cancer. So because they were able to get this information from these billing codes, they could look and realize that people with implants have a lower likelihood of breast cancer. It's not because implants prevent breast cancer, but people with smaller breasts get implants. People with smaller breasts have a higher likelihood of breast cancer. So no.
That's interesting.
Yeah,
I did not know that. I have to look for that study. You should get a mammogram before implant surgery. Yes or no?
Well, you can't say yes or no to that because it depends on your age. So I had a lady who came in the other day. She was 37, and she asked me that exact question. So, do you have any family history? No. Grandmother when she was 80. And I said, like, you probably don't need to. If you're 40, I'd say yes. 37, maybe not. But if you really want to and you'll feel better about it, knock yourself out. If someone is 40 plus, I'll have them get a mammogram beforehand. About 5 years ago, I had 2 patients, all within about a 3-month time period. They came and saw me. They were like 44 or something like that. And I hadn't gotten a mammogram. Both mammograms were negative. Put an implant in. 6 weeks, they found a mass. Got a mammogram, showed a cancer. They had a mastectomy. Okay, so this was a cancer that was very low back. They had a depressed chest wall. So the implants, the cancer's sitting behind the chest wall. Mammogram couldn't see it.
Yeah, those are hard. Dense breast?
And then, I can't remember, but and so it was pushed back. So then you put an implant in. All of a sudden, it was pushed into the field of view. And so if these women didn't have implants, they probably wouldn't have found these implants, these cancers for a couple of years. So it's important to get a mammogram, but it's, it doesn't always show it, right?
No, for sure, yeah.
But it's better.
There are definitely limitations. Yeah, I agree. One question I get a lot: implants, and this is again yes or no. Implants, do they have an expiration date?
No.
They don't have an expiration date.
No, definitely not.
Okay.
They have, like, if I take a box out, they have an expiration date. I think they last 5 years from the manufacturer's date, but they have to be in the patient by that date.
Right.
But once they're in there, there's no expiration date.
Okay.
And an implant, I tell patients that an implant, if at the year mark they're soft and healthy as they should be, they're probably going to last you 30 or 40 years, a long time. Saline implants, they don't last quite as long, but they're still, 25, 30, 35. Yeah. They last a long, long time. If everything's healthy. If you have a capsular contracture, they're going to fail in the first 10 years, almost for sure. So if they fail early, there's almost always a problem.
Interesting. Yeah, because a lot of women come in and, they'll be like, oh, well, my surgeon said I need to change it after 10 years, or 20 years. We hear it so often. Like, I had a woman, she had an implant for 42 years. It was saline.
Yeah.
Beautiful.
That's
she was
amazing.
in her 70s.
So 42 years, and they're intact.
They totally were intact. Beautiful, and then I see implants that are like 10, 20 years old and they're, deformed. So...
Well, that's the problem. Is if you have a problem, like a capsular contracture, you're going to have a problem with your implants.
Yeah. Okay, let's talk a little bit more about breast health. As a radiologist, which I am, we know that mammograms save lives, and we know breast cancer is obviously not preventable. And so the goal of us doing the mammograms is to be able to find cancer early. And one of the ways that we see cancer early is through calcifications,
Right.
which is a ductal carcinoma in situ. We do have a lot of patients with implants that come in and they just want to have an ultrasound.
Yeah.
So before I talk about that, can you, and one of the reasons they don't want to do that is because they think that a mammogram is going to rupture
Yep.
the implant, okay?
Yep.
So I would like to talk about the durability of implants, and then we can talk about imaging and implants in breast cancer. How durable are implants?
Extremely. So a brand new, healthy implant, you could probably put it on the ground and jump it up and down on it. I heard an analogy once where put an implant in someone, they fall off a 10-story building, they're dead, their implants are fine. Like implants are solid. They age. And implants move inside you, and you get creases forming, and then they go away, and they form, and they go away, and they form. And at some point, that's going to wear out,
right?
And then it gets thinner, and it's going to fail. So if you have an implant that's super old, and you were to squeeze it, that could be the straw that breaks the camel's back.
Right.
But if you have a fresh implant, that's not going to happen. I do get a lot of patients who ask about mammograms for sure. What I tell people, if you put them behind the muscle, it doesn't affect your ability to detect your breast cancer. Your self-exams are better under the muscle. They're better. You can actually feel lumps easier. Mammograms are as effective. You have the same chance of detecting breast cancer. You have the same chance of surviving breast cancer.
Absolutely.
And I tell people to get mammograms. Okay. And when they ask
That's
me...
good to know.
Yeah. And when they ask, I say, they change the technique slightly. It's not harmful to the implants.
Right.
And it's the best. And I tell people that. And there are some people who have just no breast tissue and a bigger implant because they have no breast tissue. And so like they literally have, an implant covered in this thin little layer of nothing. And some of those patients just have such a hard time getting a mammogram.
Right.
And then also we talked about earlier, like the space that was created for breast augmentation used to be big. They used to over dissect this pocket. So this implant could move around and you could push the implant into your armpit and then you have a breast and you can do a mammogram and that works great. These days, we typically try to do what's called a hand and glove pocket. So the pocket is the perfect size for the implant. It's not too small, it's not too big. You don't make it a bigger pocket. And that, I think, makes it harder to do a mammogram because there's less space to push the implant out of the way. And so I do have patients, very small breast tissue, bigger implant, and they just really can't get a mammogram. And those are the tough ones because then what do you say? You can still say, well, mammogram's the best, but if you're not going to get a mammogram because it hurts or because you're worried, you're still better off doing something else.
Yeah.
And like an MRI, which is expensive, but it shows some stuff. It doesn't show the microcalcification, but it's probably better than someone just not getting a mammogram.
Right.
And the question for you, like, can you see microcalcifications with the CT scan?
Not as well.
Because it's not flat.
They've got to be florid. Like if a person has, and I've seen it where a patient has maybe 10 centimeters calcifications, like just almost the entire breast. Like by the time you see it, it's just diffuse. And then obviously we can see, but the very fine, like, sometimes we're looking at a 5 millimeter, 6 millimeter cluster of calcifications.
Right.
And you can only see that on a mammogram. Yeah. Now, I do want to acknowledge that, there are some women, yes, that do have bigger implants or even mastectomy patients, they just, there's not a lot
There's nothing there.
There's nothing there, right? So it's not so much that the implant is bigger, but there's just nothing there. And people that have smaller pockets.
Yeah.
And we just don't displace that implant.
Yeah.
So you can still, when you have an implant, instead of getting the 4 pictures, you get the 8. But with those, we just do the compression. And the first compression that the technologists do, it's not as much as somebody that doesn't have implants. I know in our clinic, we do. Yeah.
I've had patients say that it's less painful when you have an implant than before they got implants.
Yeah.
I've certainly had people say that.
Yeah, that's because we don't put as much pressure because, like you said, we have women that are coming in with implants that were put in by your father. We don't know, have they ruptured? Is there calcification? Yeah. So it's a peak to see. And that soft compression is still enough for us to see if there are calcifications. Yeah.
and I think you agree with me. It's very user dependent or operator dependent, right?
Absolutely.
And I think if someone is really good at it, they're good at it. I had a lady I saw on last week on Tuesday, and she had a ruptured implant, and it was almost for sure from a mammogram.
How old were the implants?
They were what, 6 years old. These should not rupture.
Tell me more.
And so I sat down. Tell me your story. Like I want to like dissect every bit of this to really see if there was something else going on. And so she came with the ruptured implant. I replaced it. She thought it was from a mammogram, and I always give that a grain of salt. But I went in there, and her spaces were super healthy and soft. There's no reason why that implant would rupture, except for from some external force. So then you go back. She's had 6 mammograms. Got a mammogram every year, and 5 of them were fine. Didn't hurt. They felt great. Really good pictures. This one was terrible. She just had so much pain. It was so tight. She called her husband afterwards, said that was the most horrible thing ever. I'm going to be bruised from head to toe. It was a terrible experience. And that mammogram showed the linguini sign. Like it was an acute rupture that wasn't there 12 months ago, unless some weird thing happened. And maybe, but to have 6 mammograms, 5 of them are absolutely seamless and no pain, and then one bad one. And she thought the radiologist, the tech, like didn't know what she was doing and was too forceful and stuff. It's still hard to imagine rupturing one of those, but it's a pretty good story.
It is good. Like we mentioned, they're pretty durable, right? So, and the compression is so little. We have a tech that was working with us today actually, and she's retired, and she comes and works every so often. And I've asked her, have you ever seen that? And she goes, not really. There are obviously extenuating circumstances. Could have been trauma before? I mean, and you never say never, right? You never say never.
And I don't know for sure.
Right.
But I really sat down with her because we were talking. I wanted to really get this. I have a sheet on my desk. And I just like asked her everything. And maybe it was something else. But it's hard to find anything else in her history
that could have done that.
It could be. And I do think that the technician makes a big difference between a good experience and a bad experience.
I 100% agree. At our clinic, CDC in Calgary, my clinic does the most implants. Like most people do maybe 1 a day. We do about 5.
Yeah, so you're going to do a better job.
Yeah, and then there's a whole technique with how they do it. And for sure.
And I think that'd be a good thing is if people with implants went to the specialist, because it would probably make it much more pleasant, and they're much more likely to get it done.
Yeah, for sure. When it comes to ruptures, obviously, we can see it on ultrasound, but the gold standard is MRI, which, as you just mentioned, is expensive, you have to pay for. And, with the calcifications, we don't always get to see that on MR. By the time we see things even on ultrasound or MR, it's a little bit more advanced, but it's a mass, it's no longer a pre-cancer, and that's why I want to make sure that the listeners understand that we really want that early detection, the DCIS, to find those calcifications. And like you said, we do the best we can.
Yeah. And I'm certainly not trying to dissuade the listeners from this. It's just, and I've been doing this for a long time. And that's just this one weird case.
Yeah, there's always one or two.
And I don't think it's the mammogram. I think it's the technician. And that's just a one-off that might happen.
No, that's good to know. We'll have to talk offline about that later, maybe.
Yeah.
Let's, as we're ending off here, can you talk about breast implant associated illness? We kind of talked about that briefly with social media. What is that?
So it's this condition where you have these kind of vague symptoms. And if you have a certain number of these symptoms and you have an implant, then you can call yourself someone who has breast implant illness. This was big 8 years ago, probably about 8 years ago is when it was peaking. Luckily, it's kind of drifted down. It seems like it's kind of faded as discussion of perimenopause has increased. It is a real thing, and that the people who have it, like it really affects them. There's never been any evidence that the implant causes the problem, and more these things happen.
Okay.
But if someone has a problem, they have hair loss and they have implants, and they Google it, they're now stuck in an algorithm. They are going to be just fed all this information, and they'll never be able to get that out of their head that the
Right.
implant is causing the hair loss. We can't. There's no way to prove that it is or isn't, but they can't get out of their head. So if someone comes and sees me and says, I think I have this and my hair is losing and I brain fog and this, I say, okay, well, take them out because you will feel better. It doesn't mean it's going to make it better, but you will feel better and you'll no longer worry about these things. It's a very unfortunate thing because it really drives people to do things on fear and a bit of misinformation. And I've only had a handful of patients in my entire practice who've come and seen me and taken these out. And I've had many people who've come and taken them out, and then after I took them out, they were devastated because they loved their breasts and the problem
They come back
stayed.
and put it back in.
Yeah, I've had one person do that.
There you go.
An interesting thing, I had a patient who was getting breast augmentation, and she called us up 2 weeks before breast augmentation. She had Crohn's disease, got diagnosed with Crohn's disease. If her surgery was 2 weeks earlier, the Crohn's disease would have been from the implant.
Yeah.
So it's this time, this causation thing is the issue. It's not a causation, it's just a correlation.
Yeah.
But certainly if someone feels they have breast implant illness, if you take them out, you feel better. There's this euphoric improvement in your symptoms.
Is it covered by Alberta Health?
It can be, yeah.
Yeah? Okay.
Yeah.
Interesting.
Unfortunately, as I say, this is driven by fear. So there's surgeons who will say, oh, you have to have them out and you have to come and see me and you have to have an en-bloc resection and it's going to cost you $40,000. And this is something no one should ever do. All of our colleges, every plastic surgery college says you should never do this operation, but it's still done. And it is a damaging, horrible operation, but it's in the media that's what you have to have done. So it's unfortunate.
Interesting. What about textured implants and BIA-ALCL?
Yeah, so there's different textures. There's this is called a biocell texture, and it's a bit more aggressive than this texture, which is called Siltex. They're different companies. And the idea with these is you put them in, and the texture makes them adhere so they stay in place. And there's some real power in that implant. But the texture causes this irritation, inflammation, and it leads to this anaplastic large cell lymphoma. Super rare. When it first came out, there was something like 10 cases on the planet. And when there was only 10 or 20 cases on the entire planet, they were able to tease out the fact that these were actually related to these implants, which is fascinating. It tends to happen, peaks at about 8 years after implantation. It ranges in incidence from 1 in 60,000 to 1 in 1,000. Like there's a big range. It's location dependent. If it happens, the breast swells. Huge, big, twice the size. It's so dramatic. And then you drain some fluid out, you send it off to the lab, they look at it, figure out that's what it is, and then you take the implant out, the shell out, and that typically is curative. It's not common. It is associated with textured. There may be some cases associated with smooth.
Yeah, I did hear very rare.
And a lot of the times we don't know exactly what the implant had, what the patient had for an implant. So you're kind of guessing and assuming that maybe that is it. But there's probably, if I had to guess, a very, very unlikely chance in a smooth, a little more likely in that, and an even higher likelihood in that. Because this is a more aggressive, less aggressive, and smooth.
It's just more textured.
It's different texture.
Yeah.
But it can happen in any texture implant and maybe in any implant. The one patient I saw who had a reconstruction done 20 years ago or 30 years ago, she was the less aggressive textured, which is very, very rare.
This one.
But it can happen.
Interesting. And so for that reason, they have been taken off the market.
Well, the BioCell have, the more aggressive textured have. I think these are still around, but I don't think anyone
Hardly uses
really
them.
use them. I don't know how you could justify using them when there's this very small but risk of having it.
Right. Now, we talked about information from different plastic surgeons. You go on social media, there's all this different information. How does one find a good plastic surgeon? What do you look for?
No idea.
What?
Yeah, it's really tough, and it's hard, and I feel bad for the consumer. I don't think there's any way to find the perfect surgeon just by going online. You can't. The best website isn't necessarily the best surgeon, and sometimes the best websites the most junior surgeon just paid a bunch of money. You can go by patient testimonials. The best thing to go is people you know who've had things done. And if you know 3 people who've gone to the surgeon, they all get results, that's a pretty good thing. But if you're purely going on what their website looks like or what Instagram talks about or any social media, that can all be driven by people paying money for that. I had a very unfortunate situation. I had 2 ladies who wanted to come to see me, and my wait list was too long. So one of their husbands got online and found this amazing surgeon, like top surgeon in the world in Beverly Hills or something like that. They both went down there and they got really bad surgery. And they ended up paying probably 3 times what I charge. And then they came and saw me and I had to redo them all. And they truly thought that they really did their work and found this perfect surgeon who's going to give them the perfect result. And they both really bad results. So it's tough. If I wanted to find someone who did a great facelift, I would have a hard time finding that person. And I have the ability of talking to other surgeons and nurses across the country, and that would help me. But as just a lay consumer, it's a very difficult.
So maybe more word of mouth.
So yeah, it's not as easy as you just Google and you look at the websites and you know that can help, but that stuff can be paid for.
I do want to not leave it on this note. I do want to be able to help our listeners a little bit. You know, especially in Canada, I think we're a bit more regulated. In the States, it seems like there's difference between plastic surgeon. Different people can do plastic surgery, which is weird. So word of mouth, look for board certification.
Yes, but even that, everyone's board certified. Not everyone, but in Canada, when you do your residency, you are board eligible because our education is so good. So everyone says board certified or board eligible in Canada. In general, I think Canadian surgeons are all very good. And in the States, there's some awesome surgeons, and there's some they're very different.
It's very different.
Yeah, and I don't mean to kind of make it negative, but I think some of the really good surgeons out there, they're not driving their practice, so they're not paying a ton of money to get people in because they're just busy. Like I'm just busy. I don't need to do a lot to draw people in. Whereas some people who aren't busy enough, they have lots of time to do TikTok videos and do all this stuff, which looks good.
Yeah.
But is it good?
Right.
Or are these guys just don't have anything to do, so they're working on this. So yeah, I think by far the best thing is word of mouth, knowing people who've had that operation by that surgeon.
Right.
If you can talk to nurses, to doctors, to residents, that's very helpful. But for the most part, word of mouth is going to be where you get it from. Okay. Things like, there are some good social media sites. I think Real Self is excellent.
Yeah, I like Real Self.
I think it's real. These aren't anonymous things. And I truly think that's a great site for people to go on and learn stuff from. Okay,
I'll put it in the notes. I do hear women that want plastic surgery, but they're shy. It's obviously your breasts. It's, we're coming to a man. What can you say to a woman that's sitting there that's thinking, I want that, but, I'm a little bit shy to come in. What do you have to say?
I certainly get 5 or 10% of my patients maybe that are really shy and they're very uncomfortable. And I just say, this is uncomfortable. This is what I do all day long. And we get started and very quickly they get much more comfortable with it. They realize it's not as difficult as they think. And by the end, they're usually absolutely fine. But you do get that person. I don't think there's much you can say beforehand to make it better. They're still going to be, shy, and they're still going to be devastated about opening their gown in front of me when they don't like their breasts. It's a difficult thing for them. Yeah. But it doesn't stop people from coming in.
No, for sure. And, somebody said this to me once. I did a biopsy on a patient who I knew, and after the biopsy, she said to me, you should probably notice my areolar size. And I was like, what?
Never.
I said, no. And I say this to mention, just like you said, this is what we do in day out. We're looking at things in a very medical, through a very medical lens.
Yeah.
And so I would hope that if somebody's sitting out, out there listening and is thinking, well, I want to come in, but I can't, I want to say, yes, you can.
Yeah, and there's never a judgment. And people think that. They're like, oh, you must think these are terrible. I'm like, these are what I see all day long.
All day, yes.
You think these are terrible. These are normal. Yes. They're going to be great. Yeah, it's very true.
You talked about costs, and I know that generally that's what drives people to go, not necessarily to the States, because that tends to be more expensive, but
It could be cheaper. Florida's super cheap.
Really? Well, no, U.S. and then to other places, right?
Yeah.
Can you speak to that? Because, I've seen, not necessarily with breast, but I saw somebody in the hospital that went in for a tummy tuck.
Yeah.
Florid abscess.
Yeah.
And I'm sure, I can't imagine what you guys as plastic surgeons have to do to fix those things.
Yeah, we see, like when we're on a call, there's probably a 20% chance that someone's going to come in on our weekly call who has some disaster from breast, mastopexy, tummy, dead tissue, infections, and it's terrible. And it's sad, and I feel bad for these people. So then what do we do? Well, healthcare will help, and a lot of these foreign places love Canadians because we have healthcare. So they're just like, we have a problem, they'll fix it. No. And what we do to fix people is we'll take your implants out and we'll cut away the dead stuff and we'll sew things together. But our job in healthcare isn't to recreate that cosmetic operation.
Right.
And then someone comes to see me and they said, well, I had the surgery and it was unfortunate. It looks like this. I can never give that person my final result, ever. You can never redo that operation perfect. There's always problems. And even if you're able to improve things dramatically, there's a ton of cost to it. And it's going to cost you 2 or 3 times maybe what the first operation would have cost you. And many people go there and they get results which are pretty reasonable. But many people have real disasters. Yeah. And when you're trying to save money on cosmetic surgery, it may not be the best.
Yeah,
best thing to do.
I really want to emphasize that too. I even heard of somebody that had breast cancer and she wanted to go to the States, and I was like, and she was in Alberta. I'm like, we have amazing surgeons here. Like, this is where I would want to be. Like, I was able to talk out of it. Better. Yeah, because like you said, there's websites and social media and all that stuff, right? So that I think that's good to know. Now I know that we're talking mainly about cosmetic breast surgery, but do breast cancer patients, let's say maybe somebody has the breast cancer gene or somebody has been diagnosed with breast cancer. Obviously, we have in Calgary the Calgary Breast Health Program. Do patients have the option to, well, now that I asked that, I'm thinking of the wait list, but do they have the option to see you and be like, I want to have their reconstruction done by you, or do they have to go to the program?
They have to be done under healthcare.
Okay.
I used to do breast reconstruction, but I don't have any. I gave back my OR time in the hospital, so I can't do it. We have done a breast reconstruction here, an immediate direct implant reconstruction here in the building. This is someone from Australia who had her own private healthcare, and she's not an Albertan, so she had to pay. And we did it privately for her here, and that went great. But yeah, an Albertan can't do that, and they shouldn't. They we have such a great system for it.
Totally.
That get in the system, you're going to get a great surgeon, you're going to get the whole deal, and it's going to be all covered. So.
Okay, so I think we've covered most things. Where can people learn more about your work? So I'm looking for your website.
Oh, that's McLeodRow.plasticsurgery.ca and .ca.com. I don't know. I have to look it up.
Both work. Yeah. Both will work.
Okay. So go in there, and that talks about us and the building, and you can see before and afters. So that's the best way.
Do you comment on your recovery time? Like if somebody has, say, implant surgery, how long before they get back to work and all that?
That's probably, vaguely talked about on the website and in the FAQs.
Okay.
It's always best to call in. For me, you'll be talking to Trista. She's amazing, and she knows everything, and she can talk to you about all that stuff. And then obviously when I see patients, I go through all that stuff in detail.
Right, yeah. I met Trista. She's amazing.
Yeah, she really is. Yeah.
Okay, any final words? Anything you want to add? I think we covered most things.
Yeah, no, I don't think so. I think that was great. We covered a lot of stuff.
We did cover a lot of stuff. So I want to thank you for joining me for this honest and open conversation about plastic surgery and breast augmentation, whether it's for reconstruction, confidence, symmetry, or simply because you want to. I want women to know that they have the right to choose what makes them feel powerful in their own skin. I've been in the imaging world for a bit, and I do know that there are some judgments cast on women sometimes when they have augmentation, and
For sure.
and I'm here, like, this needs to change, because being confident too isn't just about perfection. It's about ownership and accountability, and it's being unapologetically comfortable in your own skin, right?
I like that.
Yeah, and social media, I do want people to follow you. You are on social media as Dr._Paul_Whidden. And I want to end by drawing attention to a post and comment on your Instagram account, which was dated September 11, 2024. So I'm going to end with that. And it says, "We believe character matters. Who your surgeon is on a personal level says a lot about who they are in the operating room. Do they listen to you and validate your unique experience and needs? Do they treat you with respect and compassion during your consult and follow-up visits? Do they conduct themselves in a professional manner outside the OR and portray themselves in an honest way on social platforms?" It said that Dr. Whidden is a husband and father and has the utmost respect for women, whether it was helping women navigate the emotions of a breast cancer diagnosis or validating the desire of a woman to reshape her body through cosmetic procedures. Each woman's experience is unique and needs to be met with compassion and professionalism. And it says that all the surgeons at McLeod Trail Plastic Surgery strive to keep the bar very high when it comes to patient care. And in a world where plastic surgery has become reality TV entertainment or gossip show news, we commit to leading the industry with professionalism and character. So I thought that was just a beautiful note to end it on, because that has, you speak of word of mouth. I have heard a lot about you, and this is why I chose you for this podcast. And thank you so much
you're so
for
welcome.
your time in doing this.
That was great.
Thank you.
Thank you.
Please note that the discussions and opinions shared in this podcast should not be considered medical advice. If you have any concerns or symptoms, please consult your primary care physician.